Thank you, and thanks to you who are still here. Thanks for staying, and thank you, Patricia, for asking me up to do this. So I'm going to round this out by talking about what we do know about the psychological impact of genetic testing, and I can say that we have absolutely no direct evidence whatsoever in relation to direct-to-consumer marketed tests. So we have to make a bit of a leap from the more clinical domain and see what we think about that. I'm going to be drawing together work from a number of areas. So some is work that I've been involved with personally, but I'm also picking out from the literature what I think is the best evidence that we have there. So it's casting the net a little widely to try and come to a conclusion about, well, what do we think is actually going on. Now, that's a kind of very self-evident statement. You can work the thing. What we've seen is this shift from a very classical, traditional model of clinical genetics, which has focused on rare disorders affecting families who receive genetic counselling and testing for the purposes, to begin with, usually of reproductive decision-making, and more recently for personal decision-making in the realm of late-onset disorders happening in adults. Mostly, that's the model of genetic services we have. I have to wave this about a bit more. What we've moved on to in the last 15, 20 years with the discovery of the genes for cystic fibrosis, Huntington's disease, BRCA, etc., is something which is closer to genetics becoming integrated into the broader medical sphere. And that is moving even further as we move into what would be called predispositional testing, which is where we're at with the direct consumer marketing. In other words, it's testing for genetic variants where the information is quite different. So instead of highly predictive, accurate information relevant to the individual, we're getting to this complex disorders where we have gene-gene interaction, gene-environment interaction, where it's rather unclear the extent to which the genetic variation is making a contribution to risk for the individual, but there's something we know about it's increasing the risk for individuals. So I make the distinction between predictive testing and predispositional testing. Not all classical genetic conditions are untreatable by any means, but many of them are, and the focus has been on information as an end in itself, often for difficult family decision making. Where we are going with genomics and where these companies are dragging us is towards people taking control of their health, and there being a notion that people can intervene to make a difference. But there's also been always the concern about what is the psychological impact, especially if the ability to test precedes the ability to do anything about the risk. So the sensible questions to be asking are, well, what does this do? How do when people have tests for predisposition, disease predisposition, and for these late onset disorders, do they understand the risk information they're being given? How does it impact their emotions? Does it alter the behavior? Because basically what we're saying, take these tests, find the information, and do something with it. And from a healthcare perspective, which is one of my particular interests, does this have a broader impact on the use and expectations of healthcare services? So I'm going to pull through, there we are, evidence from three broad areas. The first one are the available systematic reviews that have been conducted on genetic testing and the impacts. I'm going to present some limited data from a pilot study we did ourselves. And I'm also going to refer to the REVEAL study, which is probably, I think, the only randomized controlled trial of genetic testing, which has produced a kind of depth of data, which, and I think a credibility of data that we've not seen in some other studies. So I'm not, for those of you, who know this area, I am not going to go through every systematic review ever done. These are carefully done reviews, for those who are not familiar, carefully done reviews that have attempted to draw together all the available evidence objectively up to the point of publication. So the last one in the list is one that I was involved in. What you can see, there's an overlap between these, but what you can see is how this literature has been evolving. So by the time we completed this review, which was actually 2006, we were up to about 30 or so studies where there was extractable data. You could look at what was going on with psychological impact. I think what's really evident from the right-hand column is just how limited this data is in terms of the conditions. So these are, and I would say that, you know, a lot of people say, well, predispositional testing, when you're talking about Huntington's disease, is not predispositional testing, it's predictive testing. So even with that literature, we're still very much in the domain closer, I think, to the traditional genetics than to direct consumer marketing susceptibility genetics. The REVEAL study was a randomized controlled trial in which individuals who had a family member with Alzheimer's disease and who came into the study were randomized to do two different strategies. And the third study, so I'm going to give them more in detail. And the third study was the one that I was involved with. I just thought I had to put up a nasty picture. So thrombophilia, deep vein thrombosis is and this is an example. The reason I put this up is that this is an example, I think, of truly predispositional testing rather than predictive testing. So deep vein thrombosis, as we know, is a serious medical condition. It can be difficult to diagnose and sometimes is misdiagnosed. It has a significant long-term morbidity and a quite defined risk of mortality. Prevention of mortality depends on altered behaviors, on altered risk behaviors in the individuals at risk, and also on the part of their healthcare providers. So there are some genetic variants which have been identified as being associated with this, and some pilot work in Ottawa to see, well, what would happen if you tested people for predisposition. So I feel like I'm doing, there we go. So, and this study was led by Phil Wells at the University of Ottawa. I had a master's student who got involved to do some work on this. So in this study, people who had first-degree relatives who'd had a deep vein thrombosis were offered genetic testing. And as you would predict, half had a mutation and half didn't. That's what you would expect through the play of chance. And over a period of time, psychological measures were conducted. And we captured some self-report health behavior 12 months on. So let's go on to some actual results. So the first question was, what about risk perception? If you do predispositional testing, does it affect people's perceptions of their own risk of the disease? The systematic reviews across the board basically appear to say, and I'm grossly summing, but appear to say, risk perception generally improves. People get a more accurate risk perception, but it's still pretty awful. So people do have a tendency often to overestimate the risk, and genetic tests don't always alter that. So being given a negative test result, you do not have the gene that predisposes to disease X, does not always alter people's perceptions of their personal risk, because it's, people build up risk ideas for a lot of other reasons other than genetics. If we look at the REVEAL study, so, and I've deliberately included all of these so that those of you who want the references can get them. The REVEAL study, I'm not sure where I'm supposed to be pointing this. So just to be clear, the control group basically had a risk assessment for Alzheimer's disease on the basis of basically of family history. The intervention group also got genetic testing. And in that group, half the people had a mutation and half didn't. So to go through this, what we see, so this is about risk perception. So what I want you to do, I don't know whether this works as a, there we go. So what we have here are the three groups, the people who did not get genetic testing and the people who did, and these are the people with the mutation for Alzheimer's and people without. When I say for Alzheimer's, I mean ApoE4, so this is not they're definitely going to get it, but it increases their risk. Now, this is a measure of their perception of their risk, and a higher number means higher self-perceived risk. And what the point of this table is that those who were negative for the mutation, their risk perception fell. And it was actually lower than those who didn't have genetic testing at all, whereas those who did have the mutation, it's the same. So it's telling you that those who did have a mutation, their risk perception is staying basically the same as if they hadn't had the genetic test, whereas those who had the genetic test and it was negative, then their risk perception lowered. In fact, the risk perception, these two should have been the same. So what's going on here is not what you would predict to go on here. Similarly, what we have here is, I know these don't come out, I took them straight from the article. These first in each of the three bars are those who were mutation negative. Then the dark ones are those who weren't tested at all. And right across, what you see here are those who were tested and didn't have the mutation felt they were at lower risk than those who just had a family history. The authors conclude that this isn't false reassurance necessarily, but it certainly points in the direction, interestingly, of possibly people saying, okay, I don't have this. Now, Alzheimer's, what can you do? Keep your brain active, take a lot of exercise, eat a healthy diet. Maybe it doesn't really matter, but if there were significantly effective interventions, this might matter. Here we go. In terms of the emotional impact, and there is a ton of research around this right from the beginning, and certainly from the early days of BRCA testing availability, there's been a lot of concern about whether this would have a devastating effect on people who tested positive. Well, from systematic reviews across a whole range of these conditions, in fact, what you find are reassuringly low levels of psychological morbidity. People are not harmed psychologically by genetic testing. What you see are people who have genetic tests and who do not have the mutation in question tend to have a sense of relief, and those who do have the mutation in question have a short-term increase in anxiety and distress, which tends to go back to baseline levels. And what seems to be very clear, the tests don't matter so much as the person. People who are resilient, and those who are less resilient are less resilient. And the best predictor of how someone is months after the test is how they were before they ever had the test done. It's about people, it's not about the tests. These are the general findings. We looked at this also with the study on thrombophilia, and these are the data from the individuals who carried and who didn't carry the mutations predisposing to deep vein thrombosis. And what you can see generally is that tracking. I mean, it's never quite perfect, but the sort of tracking from before the test to 12 months after. But interestingly and worryingly, we do see this kind of thing going on, that most people go along, but there are a few people who go off. And what we may or may not be good at doing is working out from within this group, who at baseline seem to be okay, who are the few who are going to have a problem. Here's the person, I'm not very good with this technology, am I? This person had the highest score here in terms of mood disturbance before testing. They actually, even though they're a carrier, their scores improved. So the general message is that most people do okay, but a few people go off, and how you choose those, how you pick those out, and ensure they have the adequate support, I think is the real question. Health behaviour, what do people actually do? Well, the systematic reviews tell us that we don't really know what they do. The findings are very unclear about whether people, having had a genetic test, then go on to follow the recommendations for surveillance. One of the problems is across different jurisdictions, different health practices, different countries, the recommendations for what people should do on the basis of genetic risk are quite different. So we don't really know, but there's not and from having looked at this in other areas to do with family history taking too, you know, it's not clear that people necessarily get a test result and then act on it in a rational way. There's more to it than that. From the REVEAL study, the self-report evidence was that those who had a positive genetic test did report specific behaviour change, remembering again that there isn't really anything, no, you know, intervention that's necessarily going to prevent Alzheimer's, but this study seemed to suggest that in fact the folks did take some action. And finally, just looking at impact on actual use of healthcare, well, there's actually very little data out there, and I think that's something from a health system perspective we do need to look at, because you know, we invest in health services as a common good. We want to be sure. Someone asked a question, you know, what's the impact on health services? And I'm interested in what's the non-specific impact, not necessarily going to your doctor to find out, you know, should I have this test, but also just a general increase in worry and anxiety and contact. What we found was not really an awful lot. This is a very small study, the thrombophilia study, not a lot of effect. But in terms of expectations, and this would be a whole other presentation, people expect their doctors to know an awful lot more about genetics than they do. People expect their family physicians to know more, their internists, and across the board, the fact that people expect this is not matched by internists, primary care physicians, primary care providers of any kind, feeling sufficiently confident that they can take on that role and advise. So we've got a gap between a growing, I think, expectation on the one hand of what the healthcare service and what the professionals can do, and what the professionals outside genetics feel that they're capable of doing or confident to do. So, to summarize this knowledge, for most people, most of the time, genetic tests don't seem to have serious psychological consequences. But a few people have persistent distress, and how to identify those is the big question. Risk perception is always an issue, and risk perception may not be accurate. Whether that matters, I don't know, because it's not about, if it's not causing psychological distress, having an inaccurate perception of one's own risk doesn't necessarily mean that it's translated into anything undesirable. It's what people do with that risk. It's what actions they follow. And what I would say from another piece of work we did, we were evaluating the cancer genetic services in Ontario. We did get some worrying insights of people who, women who had genetic testing for BRCA because they wanted the information to advise adult daughters of their risk, who went through testing, received inconclusive results, where it wasn't clear whether they carried a mutation or not. That's not the same as a negative test result. But they interpreted it as a negative test result, interpreted themselves as being at low risk, and then advised adult daughters, potentially at risk, that they weren't at risk. Now that would be a story of misinterpreting risk and acting on it in a way which actually could have a negative impact. That's from a qualitative study, just one study, but risk perception in itself isn't the issue, it's about what people do with it. We don't know what impact this is having on health services, and we know that primary care doctors are not confident in how they advise people. Okay, so that's clinical genetics. This is a very different domain from direct consumer marketing. So the question is this generally reassuring message applicable in this other setting? Big question mark. What's the harm of failing to identify if we don't have systems in place? So Navigenics, as far as I know, is the only company which incorporates genetic counselling into its service. The others don't. Genetic counselling is the way at the moment of finding the people who are maybe particularly vulnerable and ensuring that the decision that they make is truly informed, is the right decision for them. If we don't have that there, what difference does that make? Are people going to go through with testing who are vulnerable and who are not being picked up? And there's always the question about if you just know a test is there, is that enough to cause concern whether you have it? So who looks for genetic testing? So from the REVEAL study again, we don't know a lot, but the people who took themselves into the study, these are not patients, these are relatives of people with Alzheimer's disease who were either contacted because they were known to researchers or who nominated themselves, who found their way to the study. The general finding was that they were younger and better educated than the general clinical population. That's beginning to look a little like the DTC demographic at the moment anyway. There's a trick to this. Why do they seek testing? Well, that's a really good question, and I'm not sure that I can answer because I think Mike has done that already to some extent, but the participants in the REVEAL study were asked to kind of examine a whole lot of questions, a lot of reasons for why they were participating and why they were, what they wanted to do with the information. And they picked out these 5 factors as independently predictive of going all the way through to have all the processes and actually having the genetic testing and getting the results. And the one that I highlighted at the top, preparing my spouse and family for my potential illness, came out as the most significantly predictive. So the motivations, again, I just told the story of women seeking genetic tests to get information for relatives, for daughters. This is a similar story. It's about information for a family to use and to prepare. I think there's a significant theme in genetic testing literature about the altruistic and family orientation of information, doing it because it's going to be good for other people. Now here's a really important message, and I think one that's not been thoroughly examined. I just pulled out from one study from Bettina Meiser and colleagues. I could have picked a whole lot of other studies. This is not from the systematic reviews, it's quite separate. People who decide to have genetic tests are not the same as people who decide not to. So just to talk you through this. So this is a study where women eligible for breast cancer genetic testing were followed through over a period of 12 months. And you have 3 groups here. The top 2 are the groups of women who decided to have testing and who ended up as having a mutation or not, and then the group who decided not to have testing at all. And if you look at baseline, so these are psychological scores. I can't actually remember which measure it was, but it doesn't matter. The higher score is higher level of emotional distress. What you have are people who decide not to be testing are different from those who decide to be tested, and it follows all the way through. And so you see, even before they have testing, there's a difference. And what I would say is, people select themselves to have genetic testing or not. People who decide not to have genetic testing are doing it because they're scared, or they want to protect themselves, or they're not ready to deal with it, for a whole lot of reasons. But there's some kind of mechanism going on in there. And I would guess genetic counselling, part of genetic counselling is about helping people find their way to their own motivations, their own feelings, and their own ability to handle the information they may or may not wish to get. So just to close, people who choose to get testing may be doing so because they're inherently better able to cope with the information that results. All of the testing, all of these studies so far, all of this evidence is based on clinical populations, often, perhaps exclusively, on people who've been living with serious disease within their families. Neither of these necessarily holds for how things have played out so far with direct consumer marketing of genetic tests. So we have people who've been filtered out through genetic counselling or through their own motivations, and people have been living with disease risk. So I think we have 2 different domains, 2 different worlds at the moment. We've got the clinical genetics, which is one thing with a high emphasis on informed decision making and supporting individuals to make the right decision for themselves, for example, through genetic counselling. And we have this other world which I think Mike has described really nicely, of people who don't look like clinical populations, people who've decided for themselves they're going to go out there, and as much as anything, it's an exercise of autonomy and control and taking ownership and, if you like, completely going in the opposite way from the medical model of genetic information is not about medical stuff, it's about me and my health, it's my own. And they are really distinctly different groups of people at the moment. The question is, as that second group, if you like, I wouldn't say the group matures, but as that customer base alters, if it becomes more like clinical populations, are we going to start to see some of the issues that, and have some of the concerns that we have, perhaps, particularly about who is not having testing. If people are choosing not to have testing in a clinical scenario and being supported in that decision, even if they may feel responsibility to other family members, will that change when it's easily available? Will those filters, will those barriers and those difficulties, if you want a genetic test, it's really hard to do it. You know, you really have to work hard within the Canadian system anyway. You can't just go and get it. You've got to go through a whole lot of steps. You have to really want it. If all of those steps are taken out, are we going to have some people who would have otherwise chosen not to have testing coming into this? That's the question. And do we need the genetic counselling approach that Navigenics use or not? So I'm going to close there. I think there's a lot of questions. Where I see all of this is this is not just about medical care or not. It's kind of, we're moving from this clinical biomedical model, which is where all our knowledge sits at the moment, to this complete new world, which I think is not going to go away, and where philosophically I think we have to kind of get ourselves up to speed and say, is this genetics, is this about healthcare and medicine, or is this about something else?